Thank you, madam, for your introduction, and thank you for the VCare team for having invited me to be a part of this program. So, from the adolescent, this is supposed to be a symposium on the aging population, but my topic is such which could be actually blending with the earlier talk. So, you're going to take care of the slides, or can I do the slide? I can do it? Okay. So, I'm just going to give you a little brief. 15 minutes is not a long time to discuss glucocorticoid-induced osteoporosis. But the standard and whatever is a little new, I'll try to discuss in terms of the pathophysiology, what are the guidelines regarding treatment. And something which has now been discussed quite often is, when do we stop treatment? I mean, no one talks about stopping treatment for diabetes or hypothyroidism or hyperlipidemia. But here it does come up. And what I have done for the last couple of days is really worked on two articles, one which was in 2021 and another article which was in 2018. I'm sure at least a large number of you have already gone through the second article. The first one is something very interesting, and which is what I've referred to during my talk. We prescribe glucocorticoids as specialists, and we are aware of what are the side effects, what precautions to take, how to talk to our patients. But that's not the real picture of what happens in practice. There is a lot of prescription given for a short period, and then it goes on and on because the patient feels good. Secondly, there are conditions which are life-threatening and are remediable only when we use glucocorticoids. And third group is this post-transplant group where you're using a lot of glucocorticoids. So that we have sparing drugs, but they still need a lot of glucocorticoids for a long time. It may be a small dose for a long time. So whether the daily dose is important or the cumulative dose, both come into play. The important thing to remember is that at least 40% of these patients, if not treated and given chronic glucocorticoid therapy, will get fractures. And as I'll show you in one of my subsequent slides, the fracture risk increases very rapidly in the first few months of therapy. So it's wrong to think that I'll use it for 2-3 months and then I will start thinking about the bone health. So the awareness is low, and we don't have very clear-cut guidelines. I have at least 5 slides on guidelines, which I will not be showing to you because that would take away about 8 minutes of my talk. So let's start with this young lady, 45 years old. She's been diagnosed with SLE. It could be rheumatoid arthritis or polyarthritis nodosa or something like that. And she has been started on prednisolone 20 milligrams daily with hydrochloroquine in the hope of reducing prednisolone in the next few weeks. Her BMI is 23. She has no comorbidities. Now, what would we do when we are talking in terms of bone health for this patient? Do we really need to start treatment? Do we need to start investigating her? Or we just look at her primary problem and hope to get her off these steroids fast? So as I mentioned, when you are starting glucocorticoids, there are 2 phases of bone loss. The first, say 3 to 6 months, the patient may lose up to 2 to 9% of bone mass, and this is predominantly a trabecular bone loss. And towards the end of 1 year and thereafter, if the patient is going to be on glucocorticoids for a longer time, it's about 0.5 to 2% annually. As I mentioned, it's predominantly a trabecular bone loss, so you're worried about the vertebrae and the femoral neck. And as we understand, it's not only bone density, it's the quality of bone which suffers, and that's why the fracture risk is much more than what the BMD would tell us. Please bear with me for another minute or two because I have to tell you what the glucocorticoid does. I'm sure you all are familiar. So this is not going to work. So the osteoclasts are the first cells that really get involved. They get stimulated. The gene production and the osteoclast activation all leads to increased bone resorption. On the other hand, the osteoblasts over time, again it's a gene modification, the osteoblast functions also start going down. So the initial part, as I said, in the first few months, it's the osteoclast activation and then followed by osteoblast suppression. In addition, we have now started understanding the importance of osteocytes in the bone metabolism, and they are just not senescent cells, they are very important cells, and they also, their function goes down. In addition, as you can see at the top, the absorption of calcium in the gut is reduced, the muscle mass goes down, so there is going to be sarcopenia along with bone metabolism getting defective. There is an effect of steroids on the sex steroids. So again, we know that we were talking about anabolism and anabolic hormones. So you have a reduction in the muscle mass directly and indirectly, plus an increase in rank ligand, which is going to increase osteoclast activity. So these are multiple things which have been put together to explain the effect of steroids on the bone, and that's why we need this talk. I could have had a hand show, but no, we are running through. So this patient actually, because we are looking at a probable short duration, and her daily dose and her cumulative dose is not going into a region where you're worried about, she really doesn't need anti-osteoporosis therapy. And since we're not looking into a long-term therapy, she doesn't even need any investigations. Anyway, this patient came back for a follow-up after 6 years, and unfortunately, her condition has worsened. She's got ulcers, joint pains, blood pressure, etc., proteinuria, low complement levels, etc. So basically, the disease has worsened from a mild to a severe state. Her prednisolone dose has been increased to 40 milligrams a day. Azathioprine has been added in the hope of sparing the steroids later on. Prednisolone has been tapered, but she needs at least 10 milligrams a day. She undergoes a DEXA scan at this time. Femoral neck BMD score is minus 1.6. Her calculated FRAX score suggests a 6.1 probability of major osteoporotic fracture. Now, for those who are not too familiar with the FRAX, 10%, so we say 20% of any 10-year risk of a major osteoporotic fracture, or 3% for hip, is considered as a reason to start treatment. Here it says 6.1, but I'm going to make a point here that the FRAX also has to be corrected when the patient is on steroids. 1.15 times for the vertebral BMD and 1.2 times for the hip BMD. The fracture risk actually from various meta-analysis ranges between about 2.5, 3 times. And those who are on doses like 20, 25 milligram equivalent of prednisolone a day, it may be as high as 7 to 8 to 10 times. So this is something which is very serious. And again, just because the dose is low, it doesn't mean that they don't run the risk, because a cumulative dose of more than 1 gram in that particular treatment and can raise the fracture risk by 2.5, 3 times. So the choice of glucocorticoid therapy, there's an interesting statement that I came across, that we're looking at glucocorticoid therapy, whether it is anti-resorptive or whether it's anabolic, the same way that we look at a postmenopausal osteoporosis. But the mechanisms are totally different of these two disorders. I mean, Usha is going to tell you about postmenopausal osteoporosis. But unfortunately, the choice of therapy remains the same. So you can think in terms of starting when you are aware that this patient is going to be on a therapy which is more than 3 months, either with the standard anti-resorptive therapy. Most guidelines, whether they are from the American College of Rheumatology, the International Osteoporosis Foundation, the British societies, have been very vague about what to start. It is only the American College of Rheumatology which clearly states that you should start with the oral bisphosphonate. They have their good reasons for saying that, but otherwise, depending upon your choice of therapy, whether you want to go for a parenteral zoledronic acid or subcutaneous denosumab, the results are probably pretty good. What is also important to remember is that, I think that's there in my next, so that's the choice of therapy. we somehow don't, or we have not been using teriparatide as a form of therapy to prevent glucocorticoid-induced osteoporosis, but there is sufficient data to suggest that teriparatide is actually better than the antiresorptives in the first year and a half to that teriparatide is allowed to be used, and especially when you understand that after the initial months of osteoclast activity, the osteoblast activity is actually reduced. So teriparatide would definitely be a good initial therapy for your patients. Cost and preferences, and especially who's going to be paying for it, will also drive your choice of therapy. At 9 months of therapy, this patient has now started improving. Disease activity has decreased. Prednisolone has been tapered off. Basal cortisol is nearly 10 micrograms per deciliter. Prednisolone is discontinued at the end of the 1 year, and now she's well continued when controlled on hydrochloroquine and azathioprine. So what we are now worried is, should we continue with the antiresorptive therapy? Can we stop it? Or if yes, then when should be stopped? See, it's been clearly shown that unlike other causes of osteoporosis, steroid-induced osteoporosis reverses very well once you remove the cause. So if it's going to be a couple of weeks or couple of months and the disease goes into remission, you can think in stopping GIOP therapy, the treatment for osteoporosis. And the interesting part, enough studies, and even in Cushing's disease and Cushing's syndrome, it has been shown that between 6 months to 2 years, the bone mineral density actually becomes like that of the peers. So we continue with therapy for as long as the patient is on prednisolone or an equivalent steroid, and then think of withdrawing 6 months after stopping the therapy. Oh, yes, sir. So, as I said, I'm not going to go into all the guidelines that are there, but when we are deciding the choice of therapy and whether to treat or not, one of them is the underlying disease, the other is the dose of steroids that you're going to use, and then there is a certain amount of risk stratification, especially when it's a adult more than 40 years whose BMD scores are below -2.5, or the FRAX adjusted, as I told you, more than 20% for major osteoporotic fracture or more than 3% for a hip fracture at 10 years. These are patients whom you would think of starting treatment earlier and maybe going for teriparatide before the bisphosphonate or denosumab. So the moderate risk and the low risk are then accordingly the same things, that the major osteoporotic FRAX risk is lower. So your decision could be a little more based on the clinical situation and the underlying disease. Just one slide I want to tell you that children also we are often using steroids for different reasons, and up till now it was bisphosphonate use, but now we have evidence for the use of denosumab also in these patients. So I'm going to summarize just by a couple of points that glucocorticoid-induced osteoporosis has been around for long. We've known a lot of risk factors, but we should respect this disease in such a way that we think of starting treatment at an earlier stage and not waiting for things to become bad, like getting a fragility fracture. FRAX screening is something which we need to talk more often in our patients. They should be receiving calcium, vitamin D, muscle building exercise, weight bearing exercise, adequate amount of protein in the diet, and avoiding bone toxins like smoking and excessive alcohol intake. As I mentioned, early initiation of pharmacological therapy is very much indicated, especially when you know that therapy is going to go for more than 3 months. And most guidelines are not very specific except for the ACR, which says that bisphosphonates, the oral ones, are the preferred line of therapy unless the patient cannot tolerate the oral bisphosphonates. But the other guidelines talk about using either zoledronic acid or denosumab or oral bisphosphonates. The risk of fracture declines rapidly once the steroids have been withdrawn, and we can hope to withdraw the treatment for osteoporosis about 4 to 6 months after stopping the steroids. I have about 30 seconds, so I can just run through the guidelines. I'm not going to read it. But the first one was clear. The second one, the UK guidelines, have also been sort of non-specific in terms of what therapy to start, but everyone is very clear that please start treatment at a good time. I still have 10 seconds. Thank you very much for your patience here.